Hi, my name is Stefan Verhey from the Cardiovascular Center in Antwerp, Belgium, and I'll be speaking to you on the REDUCER-1 observational study on behalf of the REDUCER-1 investigators. So the problem that we were talking about is refractory angina, which is a major public health problem. It's affecting more than 100 million people worldwide. And every year there's 150,000 new cases diagnosed in US and Europe. The patients have a poor quality of life, they're taking multiple medications, and they have frequent hospital admissions. The good thing is that there's only a modest mortality, as you can see on the picture. And so therefore, the primary goal of treatment is to improve the quality of life and the functional capacity. We can do that by augmenting the coronary sinus pressure. And the first data actually go back in the 60s or in the 50s by Dr. Beck, who actually put a suture around the coronary sinus. This was before the era of coronary bypass surgery. And it did lead to improvement of angina, reduction of mortality, and a reduced infarct size. It was abandoned because of the coronary artery bypass surgery. But then in the early 2000s, because of the coronary sinus reducer, we were able again to improve the angina, improve ischemia, and improve coronary microvascular function. And we do this with the sinus reducer. The reducer is a mesh. It's a unique laser cut mesh that is mounted on a balloon expandable system. And the balloon has an hourglass shape, so that the reducer actually is an hourglass shaped device that goes into the coronary sinus that is conforming to the typical anatomy of the coronary sinus. There is a larger diameter at the proximal part, there is a neck in the middle, and there is a smaller size at the distal part of the device. The total length is 22 millimeters, and the way it is implanted is as following. It is a jugular approach. It's a 9 French sheet that goes into the right jugular vein. It's an over the wire. You engage the coronary sinus, you put a wire, and then you implant in the proximal part of the coronary sinus. You need to make sure that there is an overexpansion of about 10 to 20% to ensure proper apposition to the vascular wall. And because of the design and the struts, it takes some time before the reducer starts to function. And so this is important to get this message across to the patients also, that it will take probably 4 to 5, 6 weeks before they will have an improvement. So we investigated that in the randomized sham-controlled trial, the COSIRA-1, which was published in the New England Journal. And we obtained a significant improvement. The primary endpoint was reached with a p-value of 0.02. 71% of the people who received the reducer had an improvement of 1 or more class CCS reduction, and 35% had a class 2 or more reduction in CCS class. At the same time, people who did receive the reducer had an improvement in Seattle Angina Questionnaire Quality of Life score. And so that was taken in a PMA study. It was an observational study, multi-center, at several sites in 25 sites in 9 European countries, and we enrolled 400 patients. The primary endpoint was a reduction in CCS class at 6 months. We looked at device and procedure-related peri-procedural SAEs through 30 days and MACE through 30 days. Secondary endpoints were continued assessment of CCS class, changes and MACE throughout 5 years, 6-minute walk test, and then the quality of life questionnaires. The key eligibility criteria are the following. As in COSIRA-1, symptomatic coronary artery disease with chronic refractory angina, classified as CCS grade 2, 3, or 4, despite attempted medical therapy, and the subject had to have limited treatment options for revascularization by CABG or PCI. And of course, there had to be evidence of reversible myocardial ischemia. Patients who had an acute coronary syndrome within 3 months prior to enrollment were excluded, as well as a mean right atrial pressure greater than 15 millimeters of mercury during the procedure. Obviously, patients who did not have the suitable anatomy were excluded from the enrollment. So all in all, 400 patients were enrolled. We ended up with 382 in the safety analysis cohort because some did not respond or meet the inclusion criteria. Some of them withdrew consent, and then others were withdrawn by the investigator. We had 371 as a treated cohort, and then the patient population at 30 days consisted of 369 patients, and we had a follow-up of 361 patients at 6 months, which is 99% follow-up compliance, which are fantastic numbers. The baseline characteristics can you read here. Patients were about 70 years old, predominantly male patients, 78%. But as you can see, these patients were really sick. 75% almost had previous bypass surgery. More than half of them had myocardial infarction. 75% almost had previous PCI, and there was many risk factors. All had coronary artery disease. Majority of the patients were in class CCS 3, and as you can see, a lot of these patients took several medications as an anti-anginal treatment. So here is the results. The significant CCS class improvement at 6 months, which is very much in line what we have seen in the COSIRA-I data. As you recall, 71% in COSIRA-I had a class 1 or more improvement. Here we have about 70%, which is very similar. And also, like in COSIRA-I, 25% of the patients had a class 2 or more improvement. Now, when you look at these data, 72%, you start off with 72% class 3 or 4 patients, and at 6 months, only 18% of the patients are still in class 3 to 4. So a significant improvement in CCS class. And when you break it up and you look at the different classifications, 7.6% of the patients were in CCS class 4, 64% were in class 3, and almost 28% were in class 2. Now, unlike COSIRA-I, we also had patients in class 2. In COSIRA-I, we had only class 3 and 4. And when you look at what is happening at 6 months, you see that in class 2, there is 45% of the CCS patients that improved. In class 3, 79% of the patients improved. And then in class 4, 85% of the patients improved who were in CCS class 4. So basically you can see that the higher the class you are, the more likely you will have reduction in CCS class. When we look at the secondary endpoints, and for instance here at the adjudicated events, there's a very low rate of events that is happening. Myocardial infarction was assessed by biomarkers, and we saw that there's only 1.1% device or procedure-related SAE within 30 days. There was no death, there was 0.8% myocardial infarction, and there was a 1 cardiac tamponade on the date of the procedure, which was resolved 2 days after onset. And otherwise, there were no other significant events. And here again, you look at the MACE. There's a very low MACE rate at 30 days. There's no death. Major stroke was absent, and 1.6% patients had a myocardial infarction. As I mentioned before, we looked at secondary endpoints such as quality of life. And here, this is the Seattle Angina Questionnaire. And as you know, the higher the SAQ score, the better the result is. And you can see that in all of the 5 parameters that is composing the SAQ score, physical limitations, anginal stability, anginal frequency, treatment satisfaction, and quality of life, there's a highly statistically significant improvement in each one of these parameters. Same goes true for improvement in EQ-5D-5L score. Here we're looking at lower percentage of patients, which is a better result. And in all of them, except for the problems with self-care, there is a significant improvement. So problems with mobility, with usual activities, with pain or discomfort, and with anxiety or depression, in all of them, you have a significant improvement of these symptoms. One of the other main findings here is the 6-minute walk test, and you can see here that at 6 months in all patients, 10% improvement in walk distance at 6 months, and this represents a clinically meaningful improvement in 6-minute walk test as seen and reported in the literature. So at baseline we go from 325 meters to almost 360 meters, again highly statistically significant improvement. These were results at 6 months, but we also looked at 3 years, and these data support the fact that the data are durable. You have sustained improvement, both in terms of CCS class reduction from 72 to 18 to 11% at 3 years, as well as improvement in SAQ overall quality of life. Patients improve at 6 months and remain improved down to 3 years. So in conclusion, the Reducer-I evaluated the shockwave coronary sinus reducer in patients with refractory angina despite optimal medical therapy and had limited revascularization options. We saw that there was safety, and the effectiveness outcomes were consistent with the CORSIERA randomized controlled trial published in New England. And this is presenting a real-world patient cohort with a low 30-day SAE and MACE rates, a significant improvement in CCS class and quality of life at 6 months. All data were sustained throughout 3 years, and we are very much looking forward to the results of the CORSIERA-II US IDE randomized controlled trial that is still currently enrolling. Thank you very much for your attention.